My name is Sambit Mandal. I'm a cardiac electrophysiologist at Wichita, Kansas, and I'm going to present my data on the experience of Chilli 2 ablation catheters, which are internally cooled catheters for left atrial ablations. We are here at Heart Rhythm Society meeting at Denver, and I'm presenting an abstract with this particular experience. As we all know, atrial fibrillation is a very common problem in the United States. It affects about 2.2 million people, and about 40,000 are diagnosed every year. Left atrial ablations have been a very effective method for maintenance of sinus rhythm, and several ablation technologies have been used. Irrigated tip catheters have been the most popular. However, closed-loop irrigation systems like the Chilli 2 catheter, which is made by Boston Scientific, there has been fairly limited experience of this catheter being used for atrial fibrillation ablations. There were initial concerns about char formation and increased thrombus formation reported in vitro studies, which have essentially dampened the enthusiasm in the past about the use of this particular catheter for clinical experience. So no clinical data of any large-scale studies exist as of today. Our initial reasons for using a Chilli 2 catheter for atrial fibrillation ablations have been mainly to avoid fluid infusion. Bidirectionality of this catheter was probably the only catheter at that time, and it was very useful to use this catheter with the bidirectionality because it increased the ease of doing the cases. The pump setup for this particular catheter is much easier. The local electrograms were much easier to read. Lesion science supported that effective lesions could be achieved at lower power, and char formation could be avoided by limiting the time spent at any given location. So the results of our study is we enrolled about 186 patients from January of 2007 to November of 2008, of which 94 patients had a 12-month follow-up, of which we present the data in this particular Heart Rhythm Society symposium. For paroxysmal atrial fibrillation, we did pulmonary vein antral isolation ablations. For persistent atrial fibrillation ablations, we did pulmonary vein antral isolations along with linear lines of ablations along the roof of the left atrium, and also linear lines of ablations from the mitral valve to the left inferior pulmonary vein, and also from the right inferior pulmonary vein to the mitral valve. In all patients with persistent atrial fibrillation, we also did a linear line of ablation along the cavo-tricuspid isthmus, and in patients who had the fractionated electrograms within the coronary sinus, spot ablations were done within the coronary sinus also. The ablations were done in a drag and burn fashion so that we could avoid concentrating the energy at any particular spot for any length of time. Temperature control mode was used for ablation and not power control mode. Maximum power of 30 watts and up to 42 degrees centigrade was used. Special attention was paid to coronal zones between the pulmonary veins, as we felt that was a very important site for achieving electrical isolation of the pulmonary veins. The follow-up included the symptom monitoring of the patients. At 2 weeks, the patients underwent a 12-lead EKG. At 1 month, 24-hour Holter monitor was done. At 3 months, 6 months, 9 months, and 12 months, patient underwent 1 month even monitor recording with auto triggers for atrial fibrillation. Any atrial dysrhythmias which are noted for greater than 1 minute was considered a recurrence. Up to 2 cardioversions were allowed for the first 2 months after the index procedure. Typically, antiarrhythmics were discontinued at 3 months. So the results were we achieved an 81% success rate for maintenance of sinus rhythm at 12 months, with 94% of the patients being off all antiarrhythmics, period. Paroxysmal atrial fibrillation, we had a higher success rate of about 88%. In persistent variety of atrial fibrillation, the success rates were about 72%. 11 out of 18 patients who had recurrences of atrial fibrillation agreed to undergo redo ablations, and after redo ablations in paroxysmal subset, the success rate increased to 98% at a 9-month follow-up, and for persistent subset of patients, it was an 84% success rate for maintenance of sinus rhythm at 9-month follow-up. For low EF and age group greater than 80 years, the success rates were lower at about 66%. As far as complications are concerned, we saw one minor cerebrovascular accident in one patient, and one patient suffered from gastric bloating in the entire 24 months of follow-up. In the entire 12 months of follow-up, apologize. In conclusion, we feel internally cooled Chilli 2 ablation catheters, which are 4mm tip, are an effective and safe alternative for atrial fibrillation ablations. The concerns which have been in the past about stroke risk and bubble formation and clot formation on the catheter, we did not see that during our study. In addition, I think so the reasons might have been that we did our ablations in a drag and burn fashion. The amount of time we spent on each spot was less than about 5 to 6 seconds, and we prefer to come back to a particular spot rather than staying at any particular spot for any length of time. Effective lesion sets were probably why we had a higher success rates. Of all the pulmonary veins, which were about 800 pulmonary veins which we saw during the entire study course, only 3 pulmonary veins could not be isolated. We made sure that the pulmonary veins were isolated in each case, and isolation meant both entrance and exit block. And I think that might have been why we had a higher success rates, although the studies are pretty preliminary, but I think it provides a very effective and safe alternative for atrial fibrillation ablations. Thank you.